is Nofel Mayouf, and I am dental student at King Saud bin Abdulaziz for Health Sciences. And I'll be serving as your moderator for this afternoon scientific session. In this session, there will be 5 presentations. If you have a cell phone, please see it vibrate during the session. Before we get started, I would like to introduce our session chairperson, Dr. Saeed Al-Ghamdi and Dr. Abdurrahman Al-Safan. Dr. Saeed Al-Ghamdi is a graduate of National University School of Dentistry, GCI certified in infection control, Master of Medical Education from King Saud bin Abdulaziz University for Health Sciences, National Guard. Dr. Al-Ghamdi is a supervisor of infection control in dental department, Riyadh region. His dental career spanned over 23 years, and his role is dentist, infection control, coordinator, a speaker, educator, and clinical instructor. Dr. Al-Ghamdi is passionate about infection control and safety and has educated thousands of dental professionals and students through writing and lectures. Dr. Abdurrahman Al-Safan is a clinical director at Riyadh Al-Ilm University Hospitals. He's the community project director at Riyadh Al-Ilm University. And Dr. Safan also currently serves as the secretary IEDR Saudi Arabia division. Now, moving along to our session, please welcome the chairperson for the first presentation, Dr. Saeed Al-Ghamdi.
Assalamu alaikum, good afternoon. Our speaker for this afternoon, Assistant Professor Mohammed Al-Kilzi. Dr. Al-Kilzi graduated in 1997 from the University of Aleppo. He specialized in pediatric dentistry in the University of Damascus in year 2000 and from the University of Greifswald in year 2007. In 2009, he obtained a PhD in the Department of Preventive and Pediatric Dentistry of the University of Greifswald. In 2013, he has taken up the position of Associate Professor in the Department of Preventive and Pediatric Dentistry, Center for Oral Health, University of Medicine, Greifswald in Germany. Besides his involvement in educating under and postgraduate students, he is leading many research projects in preventive and pediatric dentistry. Dr. Al-Kilzi has published many scientific articles in English, German, and Arabic. He also participated in editing some books in pediatric dentistry and cardiology. His point of interest is improving oral health in children and adolescents. Let's welcome Assistant Professor Mohammed Al-Kilzi to present modern caries prevention at the group level, the Greifswald concept for practice settings.
Dear Chairman, dear Organization Committee, thank you for having me today. Dear colleagues and guests, thank you for being here. Assalamu alaikum wa rahmatullah. My presentation is about modern caries prevention at a group level in practice setting. I mean with the practice setting here is in the university clinic or private clinics also. For new colleagues, they were not here yesterday. I'm coming from Greifswald, is a small city in northeast of Germany. It's a small university city, lays on Baltic Sea, 250 kilometers from Berlin. This is the old city center in Greifswald, and this is Greifswald in summer. This is the river Rik, which goes in the Baltic Sea. ceiling boards. And this is our dental school and clinic. This is the Department of Preventive and Pediatric Dentistry. The department is designed for children. And beside undergraduates program, we have also master program in pediatric dentistry. This program is available for national and international postgraduate students. Our treatments cover the wide spectrum of pediatric dentistry, also under laughing gas or general anesthesia. Minimal invasive treatments are important part of our practice and research field. We will see these approaches in details at the end of this presentation. Prevention is also a very important part of our work. The elements of this presentation are, first, So the elements of the presentation are caries epidemiology in Germany, caries decline and the new challenges in practice, evidence for prevention program, recall system according to caries risk and insurance status. And I will present also some non and minimal invasive treatments, such as arresting the caries by remineralization, proximal sealant and caries infiltration, and enamel regeneration with self-assembling peptides. First, caries epidemiology in Germany, caries decline and the new challenges in the practice. This figure demonstrates the caries decline achieved throughout the last 22 years in Germany. As you see, 40% caries decline in primary dentition and 80% in permanent dentition. And we have in 3 years old less than 0.5 DMFT. In spite of caries decline, still we are facing new challenges in the practice. They are caries polarization, demonstrated in form of early childhood caries, ECC, and MIH, the molars incisors hypomineralization. After caries decline, the majority of children are caries free in both primary and permanent dentition. About half of 6 years olds are caries free and have naturally healthy dentition, and about 70% of 12 years old also are caries free children. The problem is the children with high caries risk, so-called caries carriers. So we see that the most of caries are polarized in a small group of children, manifested with early childhood caries. In 3 years old, 12% of children have 95% of caries incidence, and at 12 years old, 10% of children have 61% of DMFT teeth. This figure shows the prevalence of ECC in different cities in Germany. It varies from 7% to 32%. In Greifswald, we have 9.5. This problem is caused by parents, by long and frequent contact between milk or sugary drinks in the nursing bottle and teeth, accompanying with poor dental hygiene. The problem starts by minerals loss in the enamel and developed develops white spots, and developing to cavities and resulting in late stages in total destruction of teeth. Unfortunately, most of children come to us in late stages, so we should make invasive treatments for these children. The second challenge we facing is MIH, molar incisors hypomineralization. It varies from changes in color to wide destruction of teeth. It affects permanent molars and incisors. Affected teeth are sensible to thermal stimuli, and in some cases is even daily toothbrushing painful. We investigated the prevalence of MIH in Germany with other universities and found that about 10% of children are affected by MIH. Regarding the severity of the problem, of MIH problem, the results show that most affected teeth were first permanent molar, 71%, and the most common defects were obesities, 82%, and the remaining 18% of affected teeth exhibited severe enamel defects. In conclusion, the study demonstrates severe enamel defects involving in almost 1/5 of all the MIH teeth. Children with MIH are on high caries risk and need intensive prevention program, including dental advice, dental health instructions, weekly local fluoride application at home, and frequent recalls to dentists. The treatment varies according to the severity of the case, from fissure sealant, filling, or veneers for front teeth, or stainless steel crowns for posterior teeth. Sometimes endodontic treatment is indicated, or even in tooth extraction. As we work under health insurance system, our practice should lays on evidence. So we will see if there are evidences for main preventive procedures we used in the practice. Is there evidence for fluoride, toothbrushing, flossing, or oral hygiene advice? The Cochrane reviews provide a high level of evidence. Here is a Cochrane review on the preventive effect of topical fluoride, showing a preventive effect of 62%. Furthermore, the review shows that the direction of effect was consistent. Furthermore, there is evidence that the fluoride gel with high fluoride concentrations of about 1.25% have a preventive effect of 28%. This means 28% caries reduction by using it in school-based prevention and or at home weekly. This systematic review and meta-analysis show that infrequent toothbrushers demonstrate higher incidence and increment of carious lesions than frequent brushes. Another systematic review recorded that infrequent toothbrushing may not have been the cause of increased carious lesions. It may have been related to such factors as fluoride exposure from toothpaste. So we can conclude we have evidence for toothbrushing, but with toothpaste with sufficient fluoride content. We conducted this systematic review in the name of European Organization of Caries Research in cooperation with European Organization for Periodontology about socio-behavioral aspects in the prevention and control of dental caries and periodontal diseases. In the part about proximal caries and flossing, the following findings were reported: slow progression of proximal caries, adherence to flossing is a problem. Only 18% of the participants reported regular flossing. Instructions on flossing had no effect on the reported frequency of use, even in university students. No correlation between caries experience and the reported use of dental floss. Only daily professional flossing performed in schools was associated with a clear caries risk reduction. Self-performed flossing in young adolescents didn't reduce caries risk. And toothbrushing with 5,000 ppm fluoride seems to be effective in preventing and arresting proximal caries in adolescents with a high caries risk. So we see flossing alone doesn't help. So fluoride is more important, and we don't more recommended flossing to parents of children. We concentrated about fluoride application and toothbrushing with fluoridated toothpaste. This study evaluated a preventive program for ECC in a cohort of new birth. In the prevention group, parents of newborn children got dental health advice about diet and nutrition, toothbrushing with fluoridated toothpaste. The control group include children of parents. They don't have interest to participate. And the evaluation time was 3 years. After 3 years, the results show significant lower caries incidence in preventive group in comparison to control group. On basis of evidences, preventive approaches have been established in the practice that covered by health insurance and available for every child. This prevention approach in the practice, as I see, it's covered by health insurance, and health insurance in Germany covered for every child oral and dental examination from birth twice a year, individual prevention from 6 years old twice a year or 4 times a year for high caries risk children, and fluoride gel 1.25% for weekly home use from 6 to 18 years old, free of charge. Accompanying with general health register, parents get for their child and the dental passport as a register and guidance for child oral health with schedules for recalls by dentist. Governmental health insurance cover the individual prevention program for every child till 18 years old, including dental examination. This is the codes for this program, which we deliver to the health insurance to get it paid, and also in private dental offices. The dentists do this prevention program and send the codes to health insurance to get it paid. This program, this codes, 01 mean dental examination, EP mean individual prevention. Number one is plaque disclosing, plaque and gingival, and determination of plaque and gingival indices. EP2, oral health instructions and motivation, including diet advice, and EP4 is fluoride application. It was, before 20 years, was also EP3. This was re-motivation, but the health insurance deleted it. Also, in this intensive or individual prevention, EP5 mean fissure sealant of teeth 6 and 7. And these treatments are free of charge, or these preventive approaches for every child. So these are our weapons in the battle against dental caries: the careful examination, plaque disclosing agent, toothbrushing training, and topical fluoride application. The plaque disclosing agent results in two colors: the pink colors showing a new plaque of 1 or 2 days, and the blue color showing old plaque of more than 2 days. So we show the child where is and the parents where is the places where that long time not brushed correctly. In this child, a new plaque from 1 or 2 days, seen in pink. And the child and parents see the sites with plaque and get toothbrushing advice. And we give for this enough time, and the health insurance pays enough money for this, more than filling or tooth extraction, or sometimes pulpotomy or pulpectomy. Our dental students learning to carry out the prevention thoroughly and accurately, and to confirm and ensure the importance of prevention measurements they get more points for prevention than for restoration in the pediatric course. In a clinical course for undergraduate students, a video recording of communication and preventive procedures and treatments will taken. And these recordings will be later discussed and evaluated with students for feedback. Also, our dental students have in the preventive and pediatric course, they should present every two students. They work together on the chair. They should present a short case presentation every semester at the end of the weekly lectures. The first and second permanent molars during eruption are in infraocclusion position and hardly to be reached by toothbrush, and as you see here, and therefore these teeth are on high caries risk, as you see, first molar in eruption with already initial lesions. Parents and children with erupting permanent molars get special advice to brush their teeth from the side. We called this cross brushing or side brushing, to brush the molars, permanent molars in erupting in a right form. Another advice we provide to parents and children in our practice, the rebrushing or supervised toothbrushing. We called it rebrushing. We advise that the child first brush his teeth, and then the parent rebrush the teeth to ensure plaque removal, and for all teeth, especially permanent molars at eruption, from first tooth till children develop fine motoric about 10 years old. And this is a good position, so the mother can see the teeth and can have more control by brushing. Diet advice will be provided about tooth-friendly diet and nutrition, and about avoiding sugar consuming in quantitative and frequency, presenting illustrations like here about hidden sugar. On basis of evidence, using of a fluoride gel 1.25% is recommended for toothbrushing once a week, and the children got it from the pharmacy free of charge with a receipt from the dentist till 18 years of old, and it is strongly recommended for ortho patients with brackets, and it should be kept away of reach of children. I would like to present in short some non and minimal invasive caries treatments. First, arresting the caries by remineralization. So dental caries is preventable and can be arrested. The slow progression of caries allows the application of minimal invasive treatments, and the three important instruments for arresting caries are fluoride, diet, healthy diet and nutrition, and toothbrushing. We see here that simple toothbrushing with fluoridated toothpaste results in inactivation of these early white spots. Signs of inactive caries are shiny surface, absence of plaque, and healthy adjacent gingiva. Also, brokerist caries could be arrested by enhancing healthy diet and nutrition, frequent toothbrushing with fluoride. The caries lesions in this picture are going inactive, dry surface, no plaque, and healthy gingiva. Proximal sealant and caries infiltration is a new approaches for minimal invasive treatment for proximal caries. As you see here, proximal caries in this dentition, nice dentition, but with a lot of initial caries approximally. And when we can use minimal invasive treatment, we use it in proximal caries in early stages, here in the yellow range, with initial lesions without cavitation. The lesion is here, in left here, shows almost no cavitation, so here is indication for minimal invasive treatment, but here with cavitation, it's contraindication for minimal invasive treatment. Why we can use minimal invasive treatment? This table shows the slow caries progression in the enamel. In deciduous teeth, a caries lesion need 2 years to go through the whole enamel. And in permanent teeth, it takes long time to go through the enamel. For here 6 years molars, in 10 years old take 5.5 years, and for older adolescents take till 8 years. This figure, the figure on left, illustrates the proximal sealant on initial lesions here in red, and the infiltration, caries infiltration, is infiltrating the initial lesion in the deep, providing more retention and caries arresting. So this is the procedure of proximal sealant, tooth separation with orthodontic module, investigating the non-cavitation of the lesion here in the proximal lesion, teeth cleaning, rubber dam, and then isolation the neighboring tooth, and etching and application of this polyurethane tape with bonding and light curing and finishing. The results show after 3 years, RCT study on proximal sealant showed more caries arresting in sealant group than in control. Caries infiltration, this is a case. Here we have initial lesion in proximal. So we applied rubber dam and then etching with HCl, a strong acid, and then drying the lesion with alcohol, and then apply the infiltrant on the lesion. Results also shows more stabilization in infiltrated lesions than control. The last minimal invasive approaches is enamel regeneration with self-assembling peptide. Here, the peptide P11-4 builds a matrix in the initial lesion and enhance the remineralization. So the hydroxyapatite could be here on this matrix, built on this matrix. And we conducted RCT on this peptide for caries treatment. You see here in this, the procedure here, initial lesions on erupting molar, where here fissure sealant is difficult. So etching the surface and applying the peptide for 3 minutes to diffuse in the lesion, and then fluoride application with Durafat to enhance or to provide fluoride in this lesion. Indication is for this minimal invasive treatment is initial lesions without cavitation, so it matches with ICDAS code 123. And the results of our RCT showed significant more caries regression in peptide plus fluoride group than control group with fluoride alone. So finally, I may suggest these two books. You may find some updates about cardiology and pediatric dentistry. And thank you for your attention. Here, this is Greifswald, the Baltic Sea, frozen before 3 weeks. So the people can walk here on the sea.
Thank you very much for the valuable presentation. Any question, please? Okay, thank you. We would like to present this certification of appreciation for the valuable presentation to Dr. Mohammed Al-Kilzi. Thank you.
Our next speaker, Dr. Anas Salami. Dr. Salami received his dental degree from Ajman University, UAE, in 2012, and get the second rank out of 150 students. He took his higher diploma as member of Faculty of Dentistry of Royal College of Surgeons in Ireland, 2014, membership of Royal College of Surgeons of Edinburgh, UK, pediatric dentistry in April 2017, and scored the highest rank in the Tri-Collegiate membership in pediatric dentistry examination, and Master of Science in Pediatric Dentistry from Leeds University in 2017, and get the first class rank. He is currently an assistant professor in pediatric dentistry at Mohammed bin Rashid University. He has several publications from 2012 to 2017. Ladies and gentlemen, please welcome Dr. Anas Salami to present the HAL technique, a novel method in restoring the caries primary molars. Please welcome Dr. Anas.
Assalamu alaikum. Thank you for the nice introduction. Okay, so good afternoon, everyone. Slideshow, please. Yes. So good afternoon. So today our talk will be about the HAL technique as a method, a novel method in the restoring the caries primary molars. So the question arises now here: should we always drill? Should we always give local anesthesia to the teeth, to the very young children? Do we always need to drill and give local anesthesia? So as you can see in this slide, we have two cases. Both of them, they have dental caries, previous restorations, recurrent caries. So the treatment can be now different. Either we need to drill the teeth and we give local anesthesia and restore them, or we can have the other alternative which we're going to talk today, which will be the biological approach. So the first case, on the left side, we give local anesthesia, drilling. We drill the caries, we remove the caries, and then we fill the tooth and we place the stainless steel crown. Whereas in the other case, on your right side, you can see that they were only whole crown. So the final, they both look the same. But the treatment of how do you approach and reach to this treatment differs. So the future direction, the next practice for all the healthcare specialists is that we have to improve the care for our patients. But we have to always make sure that it's the treatment that's being provided through the evidence-based pathway of the care. So the amount of evidence, as you know, the higher you reach to climb to the top of the mountain, it's harder and it's more stronger evidence. So as you can see, the amount of the evidence, the higher you reach to the top of this mountain, which is a meta-analysis, which provide you with the best and the highest evidence of the practice. And the next is the systematic reviews, and then critical appraisals, and randomized clinical trials. And least is when you go to the case reports. So the best evidence is when you have the meta-analysis and systematic reviews. So we need always to translate the good science into the clinical excellence. So what are we going to achieve today? So we are addressing the myth of the minimal intervention, the biologic technique or biologic approach in the management of the dental care in primary dentition. And where is the minimal intervention, which is no drilling approach, appropriate? And where is totally inappropriate to use the minimal interventions? So the future direction in order to offset the criticism is what good quality care looks like. How we providing the good quality of the care to our patients. Do we recognize quality? What type of the qualities are there in our practice? And what is the quality of the care? Is it only posh fillings? So here an example of we had an uncooperative or a pre-cooperative, which is a very young child, at the age of 3 years or 2 years, or a child attending to your clinic, and you have different treatment approach. Previously, we used to either to restrain the child, give local anesthesia, drill the tooth, and do the filling or restoration, and the patient will never come back. And this phobia will stay with the child until the child gets older. So what kind of treatment do we need to do for this kind of uncooperative or pre-cooperative child? As you can see, we managed to, the patients did not have very deep cavities. Patients had always, here in all the teeth, we can see a band of dentine between the caries and the pulp. But we managed to crown all the teeth. Then this patient was referred for us to do it, to manage the dental caries under general anesthesia. And these treatments were done in the dental chair without any local anesthesia and drilling, and all the teeth were restored with the stainless steel whole crowns. So other alternative which we used to practice it very commonly is to do this treatment under general anesthesia. So recently we have found that there are a lot of failure of dental treatments which has been done under the general anesthesia. Children with dental caries treated under general anesthesia tend to have a high susceptibility to future caries development relapse due to, could be poor parents' compliance or unfavorable eating practices and unsupervised oral hygiene practices after dental rehabilitation under GA. It's very important. Whenever you take your child to general anesthesia, make sure that you have worked with prevention and education of the parents. What we do usually in our practice, whenever we have a referral for a general anesthesia to us, we take the child for the 2 visits of prevention clinic for the children and for the parents. We make sure that the prevention is working well before general anesthesia, and then we take the child to general anesthesia if it's not an emergency. Because we need to make sure that after general anesthesia, patient is taking care of the prevention by themselves. And we don't want to have the repeated general anesthesia every year or every 2 years. So always prevention is the key factor. We always say, my supervisor he used to tell me that if you don't do prevention, it's like you are changing the windows in a burning house. So when the house is burning, don't go and change the windows. We need to find this solution to treat the fire itself, the caries itself. So we don't go to cover the caries or to just mask the problem or the fire. So we go and change the windows. So replacing windows in burning house, it's not a prevention. So always we need to work on prevention and to reduce the caries by itself. And as we see, I talked yesterday in my presentation that the dental caries is now, it's considered as ecological disaster. It's much wider than it used to be. It's not only the sugar and carbohydrates. So education will work because the social class and behavioral and education of the parents, all this will contribute to the dental caries of the children. So you cannot manage caries without managing the ecology of the dental caries. So children who are affected with dental caries, usually they are younger. They are from the deprived or low parental education background. They are less likely to access care in a timely manner and less likely to comply with the prevention and recall protocols. So where are we now? Where with this technology and materials and the instruments that we have and techniques, where we are in our treatment and treating the children as a child and not looking at the caries only. So we have different treatment approaches. We have now to take, you can have CBCTs, we can do surgeries under sedation, under inhalation sedation, and we have nice zirconia crowns in pediatric dentistry which are very aesthetic. And now we have the biologic approach. So, and we can have the treatment with pulpotomy. So we have different treatment management approach, and we have different materials. So by now, the excellent techniques and materials are available as never before. So we need to consider all this treatment approach, all these materials in our treatment planning, and decide the best treatment plan which is in the best interest of the child. So what is the biological management of the caries? Is it only minimal intervention, or is it no drilling and minimal drilling approach? We'll come to answer that in the few slides. So as we know now, the iceberg of the dental caries, you have most of the part of the dental caries, it's hidden, as you can see in this iceberg. So only we can see the caries or the lesion when it is in the D4 or D3. When the lesion is into the pulp, the patients come with the symptomatic teeth, or when the caries is clinically detectable lesions into the dentine. But in many cases, these caries and these lesions start hidden, and we cannot diagnose them clinically. So the biologic approach aims to reshift the metabolic balance within the dental biofilm, promoting the remineralization and arresting the caries lesion. So the karyostatic restoration that's in primary teeth, which we used to have, the ART type of the restoration, we used to have like push fillings. Patients come uncooperative. You cannot give any local anesthesia. It's hard to treat the child. And patient, if you don't have governmental coverage and they have to pay for the treatment or general anesthesia, what they used to do, they used to put GIC in all the cavities for a very long time, and the patients come with the abscesses, facial swellings, and this was how it was they used to do these kind of restorations previously. So the use of the minimalistic approach is not advisable for multi-surface lesions, unless if you have a very small cavity in the occlusal lesions, then you can do. Otherwise, doing this kind of push fillings in the multi-surface caries is not effective. So use of minimalistic approach, as we said, is not advisable when you have the multi-surface lesions. Here, the Louis et al. In 2001, they did a 2 years cumulative survival in the primary teeth. They used the two types of the GICs in class 1 and class 2 cavities. And they found, you can see that the success rate of the GIC on the class 2 cavities is less than 50% or almost around 40%, which is very low. And I can say it might be effective for less than 2 years even when you use in class 1. And I don't suggest you to use GICs for a longer period of time because of the mechanical shrink and dissolution with the saliva. So what is the biggest challenge in this biologic management of the primary teeth is the pulp. First, the challenge is we can diagnose exactly how is the pulp health, what is the exact diagnosis of the pulp health. Is it always what the parents or the child complain? Is that really the correct diagnosis? How are these complaints and signs and symptoms, are they reliable to manage and to decide what kind of treatment we have to do? So the pulp health and vitality is a challenge in these cases. As you can see that it might end up any tooth which is wrongly diagnosed with the pulp abscess. So here, deep lesion not associated with any history of pain. Can a biologic approach avoid need of pulp therapy? As you can see, we have here deep cavities in this area. We have a band of dentine. We have occlusal and mesial caries with a good band of dentine. Here we have initial D1 caries lesion, and initial caries is here. So do we need to give anesthesia and drill these teeth and do the restorations? And as we know that the systematic reviews they found and randomized clinical trials now, they found that the composite restorations in primary dentition, because of the anatomy of the primary dentition, are not really successful in restoration of these caries. And according to the AAPD also, they do advise that if the caries is more than 2 surface cavities, the tooth should be fully crowned and no restoration should be done. So a new biological approach in these cases, which is called the Hall crown, the Hall technique. The name Hall, it came from the first doctor in the Dundee who was practicing it for a long time. And then she came to this idea. She was practicing for 10 years. She used to place the stainless steel crowns on the teeth without any preparation. And then she presented it and published it, and now it's named. This technique is named as per her name, the Dr. Hall. So as you can see with the Hall technique, which I'll show you in a bit now, the technique of preparation and doing the Hall crown. All these initial caries, they are not that deep. And the X-rays show that there is a good band of dentine. And the most important is that tooth stayed asymptomatic. And if you are not sure if the pulp is healthy or no, usually what I do, I place a GIC for 1 month. And if the tooth stays asymptomatic for 1 month, then I can make sure that the pulp is healthy and there is no any chance of flare-up if I place the final restoration, which is the crown. So the Hall technique, it seals the dental caries into the tooth by means of a stainless steel crown and its GIC cement with no caries removal, no local anesthesia, and no tooth preparation. It alters the caries lesion environment to no longer favor cariogenic biofilm progression. As we discussed in the initial slides, the caries, it has multifactorial, and one of the if we block one of these factors in the way of the dental caries, the caries might arrest. And same that might happen that we used to do when you do an indirect pulp capping. You might leave some of the dental, if you are very close to the pulp, you might leave some of the dental caries and seal it with a GIC and composite. So it's the same idea. If you seal the tooth or seal the caries, it will get remineralized and it will be arrested. So the Hall technique, the Dundee Dental School, they have this user manual. It's available on the Google if you search for it, and it's free to download. And here it's written the indications, contraindications, and the clinical cases and selection criteria for the Hall technique and technique of the Hall crown. So we review now the Hall technique. The idea of the Hall technique is to have a spaced dentition, or to have a space mesial and distal to the tooth that you are going to crown it. The space in the cases that you have already spaced dentition, you don't need to create any space. But if in a tight contact dentition, when you don't have a good spacing between the teeth, we need to use the orthodontic separators. As we used to place the orthodontic band for the space maintainer, or for any kind of reason, we use this space orthodontic elastics. These elastics, you place them either mesial and distal to the primary tooth with the dental caries, And after placing them for less than 1 week, because if you place it for more than 1 week, it will cause some gingival inflammation, since it's an foreign body, will accumulate more food and debris, so it will cause inflammation. And usually I'll place them for 1 or 2 days and not more than that, so you avoid the inflammation. So you place these separators between the teeth, mesial and distal, and then you will create a space. Once you remove the separators, you have the space mesially and distally, and the tooth is now ready to be a crown. So you don't need to prepare as conventional restoration that we usually take the mesial, we do mesial reduction, distal reduction, and occlusal reduction. So in this case, with the whole crown, you don't need to do any preparation. You don't need to use any local anesthesia. You just to place the separators mesial and distally, and you create the space. Once you create your space, you need to select your crown, the proper size of the crown. So as we use for any size of the crown, any trial. So once you select your size of the crown, don't push it fully, because sometimes it will be hard to remove, because I always suggest that use the smallest size that's possible for this technique to avoid any overhang, since you haven't done any preparation. So why is skill and doing twice or by third time you get to know what is the best size of the crown that you can use. So once you tried your crown, and then you place the cement. This is a trial stage, and then you fill the crown with the GIC, which is a fluoride release, and then you put the crown fully in. Either you use the crown pusher and I use both actually. You use the crown pusher to push the crown fully in, and then you ask the child to bite on the cotton roll hard on the crown tooth. And as you can see now, the crown is fully seated without any local anesthesia, without any crown preparation. And sometimes you might have a bit, because we haven't done any occlusal reduction in these cases, there might be increase in the vertical height, or they might have some open bite. But as I'm going to show you some studies that show that there is no any harm, and the dentition and occlusion will be back to normal within a maximum of 30 days. So as you can see here now, this technique is very child friendly, and parents, they do like it, children, they do like it, but it's not the only way of doing the whole crown or doing the restorations. So it's one of our treatment plan. So if you have, as we mentioned the first slide, if you have an uncooperative child, patients coming with only 1 or 2 cavities, and you're working on prevention, but you cannot do the restoration and the proper restoration with local anesthesia or composite restorations in these cases. So to avoid the traumatic procedures to the child, give local anesthesia and this stuff, you can use this whole crown in this kind of very pre-cooperative or uncooperative children until you get them cooperative. If you have a cooperative child, then it might not be a case to use the whole crown, because you have your conventional method. Although it's not wrong to use the whole crown even if you have a cooperative child. This is another case. The radiographic evaluation showed that the patient has D1 cavities mesial and distally, and then we place the separator for 2 or 3 days, and then after removing the separators, you can see the spacing between the mesial and distal of the carious molar, and then here we place the crown, and as you can see, there is an increase in the overbite, but this is immediately after placement of the crown. You have around 1 to 2 millimeters of the overbite, and within 10 days maximum, I have seen in my cases that 10 days, the occlusion is back to normal. It's the same case that we do under general anesthesia. When you have the child in the dental and under the general anesthesia, we cannot, it's not reliable to check the occlusion. And although we do occlusal reduction and we do all the restorations, we never check the occlusion. Because the occlusion is not a matter in the primary dentition, because of the soft bone and dentition, they get back to normal. The occlusion go back to normal within the few days. So what are the indications for the whole crown? There must be no sign and symptoms of the pulp involvement. If you are not sure, if you have open cavities, place GIC on those cases. and wait for 1 month. And if the tooth is stayed asymptomatic, then you can make sure that there is no any pulpal involvement, and you can place your whole crown without any worries. So no sign and symptoms of the pulpal involvement, and clear. There should be clear band of normal looking dentine between the dental pulp and the carious lesion visible radiographically. So as you can see here, we have clear band in all the cases, and the cavities are not that deep. Teeth were asymptomatic. Patient has never complained of any pain from these teeth. And then we place, and this is another case. As you can see, D2, almost D2 caries on the distal part of the lower D. And here you can see clear band of dentine. So you should have a clear band of dentine, asymptomatic tooth, and tooth has no any prefurcation involvement. So indications here in detail: if you have the proximal class 2 lesions, cavitated or non-cavitated, for this kind of class 2 cavities, always we have to crown it. Whatever the way of crowning, either you can use the whole crown technique or conventional. Never use composite restoration for class 2 or more than 2 surface cavities in primary dentition. Occlusal lesion, non-cavitated if the patient is unable to accept the fissure sealant or conventional restoration. This is in case of when you have precooperative, very young child, when you don't have good isolation, or in class 1 lesion, cavitated if the patient is unable to accept the partial caries removal technique or conventional restoration. So, and now the contraindications of the whole crown is when you have sign or symptoms of the irreversible pulpitis or dental sepsis, clinical or radiographic signs of pulpal involvement or pre-radicular pathology, crowns that are so broken down they would be considered unrestorable with conventional techniques even. So these teeth that are considered to be indicated for extractions. So here is the case that we discussed. We had the caries in D1 and D2. Teeth were asymptomatic. We had clear band of the dentine. In different visits, always it's advisable to, when you want to place the whole crown, more than one crown in one visit, to do it opposite arch. So if you can place in the quadrant 5 and in the quadrant 7 or quadrant 6 or quadrant 8, don't place them opposite each other. And don't place 2 whole crowns adjacent to each other, because you will close the space once you place the 1 whole crown. So here we have antagonal crowns were placed. We had separators in place, and then we crowned all these initial cavities without local anesthesia, without drilling, and without any caries removal. So with the whole technique, the process of fitting the crown is quick and it's non-invasive. The crown is seated over the tooth with no caries removal or tooth preparation for any kind, and local anesthesia is not required. So let's talk about the open bite that might happen in some cases after placing this whole crown. Van der Zee in 2010, they did, this is the only study actually that has been done. They checked the influence of the whole technique on the occlusal vertical dimension of the primary dentition. In 48 children, the mean distance between the canine tips, here these are the canine tips, this distance, the canine tips reduced from the 2.45 millimeters before to 0.5 millimeters directly after treatment. So there was an open bite around 2 millimeters. After 15 days, the distance increased again to 1.96 millimeters. And after 30 days, with the remaining 8 patients, so after 30 days, all the crowns, all of the occlusion were back to normal in all of the cases. So 10 to 15 is most of the cases, and in some cases you might have more than 15 days up to 30 days. So one of the contraindications might be, shall we use it in an open patient with open bite? Although a study showed that it's a temporary open bite, I double think before placing whole crowns. If I have the option of conventional, why I need to do a whole crown with a patient with open bite? So reduction of the upper bite seems to be caused by the intrusion of the crowned molars and the antagonist. So they found that both molars, the crowned one and the opposite crown, they both will have some kind of intrusion. So here is a study. They found that the clinical outcome of the whole crown versus the conventional method, and is the whole crown acceptable to the children, their parents, and to the dentist. As you can see here, the type of the red one is the whole crown, and the gray one is the conventional. So we found that regarding the pain, we had only one incidence of the pain with the whole crown and 11 incidents of the pain with the conventional method. And the major failures, which is usually the pulp, when the pulp gets involved, get inflamed, we had 12 and 13 with the whole crown and conventional respectively. And minor failures, we had only 5 minor failures with the whole technique, and 45 minor failures with the conventional. And regarding the acceptance by the patients and the dentist and the child, they have 95% of them, they have accepted the whole crown, 28% accepted the conventional, and the parents or carer, 83% they prefer the whole crown over the conventional. And the dentist preference, it was almost 100%, 97% of the dentists, they prefer the whole crown against the conventional. So shall we always do the whole crown? Is it the only method that we have to do for any child or any young age? It is, I can say that it is now considered, this technique is a technique in our dentist toolbox. So we had our conventional in our toolbox, and this whole crown, it's also a new method that has been added in our toolbox. So patient selection is very important in these cases. Not every cases we need to do the whole crown. If you have an uncooperative child, you cannot do drilling, or if it's the first, or it was very helpful actually in my patients when the patient was uncooperative initially, and it's a very good method to use it for the behavioral management, since you are not using any local anesthesia or drilling. So if you have an uncooperative child, using the whole crown, it's a very good method for the behavioral management of the very young ages. So it is a tool in our dentist toolbox. Use it when appropriate. And in the dental schools, for those who are in the schools, in the postgrad, we are in the undergrad, it's not being taught in the UAE, but in the postgrad, we do teach our residents of doing the whole crown, and we were in situations that we have placed many of the cases, unfortunately, with the whole crown. It was, although it was successful, although it was child-friendly, parents were happy, and we found out our residents, they don't know how to do pulpotomy, and they don't know how to give local anesthesia after 6 months of doing every day, most of the cases treating with the whole crown. So in the postgraduate, it should be taught, but we should have a balance of having the skills of doing the conventional with local anesthesia and drilling and doing the whole technique. So does the biological approach work? There was a study done from 2014 up to 2017 by one of my colleagues in Leeds, Benny Hani. They have screened retrospectively 836 primary teeth, 4 to 9 years old of all the children. Treatment carried out by specialists in pediatric dentistry. Out of these, all of them, they remained asymptomatic. Biologic approach, which is a whole crown, 95%, 0.8%, it was a success rate. And the conventional approach, it was 95.3% success rate. So almost very similar. So regarding which treatment is more cost effective than the versus each other, is the whole crown more cost effective or the conventional method? They found that definitely the biological approach, it's less cost effective. So the mean they found that for placing only the crown with the cost of the cement was only 79 pounds. where it says the conventional mean with the cost of the doing the type of restorations, local anesthesia, the cost was 168 pounds. So is the biological approach cost effective? I can say yes. So although both have also very similar success rate, but biologic approach is more cost effective now than the conventional treatment. So here's another study by Ludwigs. They compared the placing the stainless steel crowns using the Hall technique and placing the stainless steel crown with conventional preparation and local anesthesia. They have followed up to the 10 years with the conventional and up to the 3 years for the Hall technique, and they found that they have similar success rates. So here is another by the Nicola and Ines, the Hall technique, a randomized clinical trial of a novel method of managing carious primary molars in general dental practice, acceptability of the technique and outcome at 23 months. They found that the Hall technique, the clinical failure there was only 2, and both clinical and radiographic failure it was 1. Versus the conventional, they found that there are 12 cases clinical and 5 cases they had both clinical and radiographic failure. So you can see they found with this randomized clinical trial, they found the Hall technique to be more successful. So scientific approach in the hands of the specialist. Both treatment approaches are equally good. We need to have a proper case selection, and it is considered now it's a scientific biologic approach, and evidence has shown that it is considered as one of the treatment options for treating the very pediatric patients. And and has been shown that it has been caused lower number of the GAs in the UK. The state of the children's oral health in England, they found that the number of the doing the treatment under general anesthesia has been reduced. So how can we achieve success with minimal intervention? By correctly assessing those teeth, maximizing the prevention, and manipulating the environment. So this is another case of all whole. With this paper we have published it. So we call this all whole. So all the molars were treated by Hall technique. So as you can see, they all had caries with the asymptomatic. They were asymptomatic with a good band of dentine. So all the 8 molars, primary molars, they were we have treated with the stainless steel crown using Hall technique. So and we have 3 years follow-up now, and you can see these bite wings of 3 years follow-up. Teeth are clinically and radiographically they are all sound and successful. So regarding prevention. This guideline, this is from the Department of the Health, from the NHS, where they have the good, if you can download it online, they have delivering better oral health and evidence-based toolkit for prevention. Regarding prevention, you can find all this information in this document. So dental caries, should we still drill? Yes, but where we feel if it is of overwhelming therapeutic value for the patients, and challenging your conventional dogmas. So I can say now, biologic approach has been added to our toolbox successfully. Use it when it's appropriate. And this guy has a lot of these instruments and equipment. I don't know if its sterilization were done or no. And with the whole crown, he can treat it in the street, just placing the whole crown if the teeth are spacing. So I think we will save his time a lot. So in conclusion, as we said, we need to be evidence-based. Now the evidence, they do show that the whole crown is successful. Randomized clinical trials, systematic reviews, they all have proven that the whole technique is one of the techniques which is proven to be successful. But you need to make a good case selection, and we need to know how to do it. Thank you very much.
Thank you, Dr. Anas, for this nice presentation and very informative presentation. Still, we have time, so we can receive one question from the audience.
السلام عليكم.
Salam.
Thank you, Dr. Salami, for your presentation. I'm Dr. Saleh Ajlam, pediatric dentistry resident in King Saud Medical City. My question to you, would you use this technique in teeth with marginal breakdown, especially that you showed in the last case there is a marginal breakdown? Dr. Hobson said that in 1970, when you have a marginal breakdown in primary molars, over 50% of the primary molars had irreversibly inflamed pulp.
Yeah.
Moreover, would you rely on the history of pain as a way of determining the pulp status, as in the GIC situation? Especially that we use these techniques in young children where the history of pain is not reliable.
I do agree.
Thank you.
Yeah. Thank you so much. That's a very good question. Yes, it's a very valid question. So, according to the Monty-Dougall in 2001 and Casa et al. In 2003, they used to say that if you have marginal breakdown of the primary molars, the pulp is most probably it's inflamed. But my question is that inflammation will cause any pulp necrosis or pulp inflammation, or is just as a histological study? That was my first question when I heard about the whole technique. That okay, I know the Casa et al. And Monty-Dougall also, they found that if there is marginal breakdown, the pulp is inflamed. And when I did my training in the undergrad, we used to any deep cavities to open the pulp and do the pulpotomy and do the crown. That was. But the studies now they show that that inflammation, histologic inflammation.
and in the social and economical issues in the patients and their families, and what roles does the school have in preventing and promoting the oral health of the students and the school environment in general. And also the role of primary health care centers. We have many primary health care centers, as you know, scattered all over the kingdom, all over the 20 health regions, which mainly focus in the curative part of services, whether it is dental or medical services. This is a potential place, potential resources of prevention also. What was the vision of this initiative? It is a pioneering initiative in oral health promotion in the school community, contributes to achieving the national oral health goals, and meets the aspiration of the economic and health transformation program 2020 and the Saudi Vision 2030. And the mission of this initiative is to promote oral health of school community through a comprehensive initiative in active partnership with governmental agencies and private sector, and implemented by qualified personnel highly convinced and efficient in their preventive role. So it's, we are trying to target not only the children, but also as like other stakeholders, like decision makers, all over the people. We need all to work for prevention. The levels of implementation, we have the center at the central level at the Ministry of Health headquarters, which there is a committee now which is following all the 20 regions in the field implementation, and we do also evaluation for the cities, and in a weekly basis. So each week we are following on the KPIs and the performance indicators of all the regions. There is a regional committee also in the Directorates of Health Affairs, as I said, the 20 directorates all over the kingdom. The third level is the primary health care center level, where the dental team there, the dentist, or dental hygienist, and they will have a good relation with the schools in their localities to implement the initiative. And the fourth, which is the most important level of implementation, is the schools, because this initiative is mainly a school-based initiative. This is the different domains of the activities that take place in this initiative. Training of the teachers and the health advisors of the schools, training of the dentists also as a TOT model, the health education programs and the activities, and dental examination and screening, and the group toothbrushing in the schools, fluoride application, topical fluoride application, and referral to do sealant and treatment for permanent teeth. So this is, we try to link the school-based and the school-linked approaches together in one program. So it is like an umbrella program that covers all these activities in a school-based and school-linked approach. So if you talked about the health education, dental examination, group toothbrushing, fluoride application, all these are school-based activities. The training and the referral is a school-linked approach. This is some of the field photos where our regional teams and the dentists and the dental assistants are doing their several activities in the initiative, starting from the clinical examination to the toothbrushing campaign, toothbrushing activities in the school, and distributing of the samples, the free samples of toothbrushing, toothpaste, and also the topical fluoride application. The target group, as I said, is the primary school children and also the teachers through the training activities, and also the parents through the messages that they will receive from their children, and the consent form, which has some information also regarding the preservation and the prevention of oral health. The goal of this initiative is to promote oral health of primary school children. The specific objectives for that is to raise the awareness and knowledge of oral health among children, and to build skills for oral health prevention, and to create supportive school environment, and to activate the role of teachers and parents in the promotion of oral health, and to achieve national goals in reducing prevalence of dental caries. So it is in line with the oral health promotion strategies and the Ottawa Charter for Health Promotion. Also, one of the objectives is to reduce the government expenditure in curative services, and to allocate more resources in the prevention in the prevention way. It was launched as one of the Ministry of Health initiatives for primary health care development. There is maybe around 9 initiatives which was launched in 2016 in the field of primary health care development, one of which was this initiative, and it was implemented in 3 phases. Phase 1, which was the beginning, we implemented as a pilot. It was implemented in 3 areas: Riyadh, Jeddah, and Dammam. The phase 2, which was in year 2017, it was implemented in 11 regions out of the 20 regions, and the third phase, which is currently now taking place in all the regions, and the implementation started in the late 17 until now. This is just a brief statistics in up to 15 March, starting from the beginning of 2018 up to 15 March. And as you can see here in the number of schools, we have target of 1,392, and we covered 1,430, which is more than 100. We almost reach our targets in the number of schools and in the dental screening of children. However, in the issue of topical fluoride, we didn't reach our target, and this was partly due to shortage in the provision of topical fluoride, and we are working on that issue now. Okay. And the health education activities was also reached in a good percentage, also with the toothbrushing training of children. So we are not concentrating only on health education activities. We are trying to build the skills and knowledge of how the children can use their toothbrushes in a correct way. Those are the KPIs which are collected weekly from the regions, and this is some of the KPIs which are monthly reported. So we have monthly reported and weekly reported indicators, and as you can see, as you can see here, the number of children referred for sealant, we are referring the children who are indicated to have sealant placed on their teeth, and the number of children who actually received sealant. There is a huge gap. Okay, we have only 3.8% of the children who should actually received the sealant. It's also in the number of children who referred for restoration. Okay, I mean in the permanent restorations, there is only 3.9% of actual receiving of the restoration. Why does this gap exist? Many reasons behind this. First of all, this is not it's still for February, but some of the regions they didn't report it until now. Inshallah, we are tackling this issue in the new forms of reporting and in the new electronic system which will be implemented shortly. How we are evaluating the initiative? As I said, we concentrate mainly in the process administration, in the process evaluation, in the administrative and facilities, and also the output, like the number of students get benefited of different activities, and in the outcome in prevalence and incidence of dental caries. There is a few points which I think it's a strength point about this initiative. It encourages creativity. It's not rigid or fixed or planned in a strict way that our colleagues at the different regions cannot play around, cannot change some of it. No, it is an area of creativity. We always say to our colleagues, it's your role now to implement it the way you like. Just we have this general guidelines, you just follow it, which was clearly stated in the manual, and it's open for any creativity idea. There is different activities also in this initiative. So it's not only a clinical examination, it's not only or field examination, it's not only health education, it's not only fluoride varnish or fluoride gel application, it's not sealant program, it's all in one. Also, it is a nationwide initiative. We are not concentrating in one region. We are doing this for all the community. And one of the strengths of it also is the simplicity of it. It's not that rigid or difficult to implement, difficult to report, and the people are having nice way of reporting in majority of areas, but some areas they have some kind of trouble in the reporting, and this will take a few times inshallah, and it will be resolved. What obstacles we are facing? Manpower, in terms of number, in terms of their belief in or their adoption of preventive strategies, and we are trying to invest more in this with the training. The funding issue also is an important obstacle here. As you know, we don't have now a special budget for preventive programs, but I think this will be shortly solved by the new direction and the new approach at the ministry, and concentrating on the preventive issues. The nature of the problem, the nature of dental caries, the natural history of the caries is also an obstacle. You cannot just eradicate it or prevent it in a one initiative. It is a multifactorial disease that needs lots of effort, continuation of efforts in order to eradicate it or to change the picture and the situation in the kingdom. What future development we work on? More portable dental units. Now we have around 100 portable units all over the kingdom. We are pushing now towards the provision of around 200 to 200 new portable dental units, and also fixed dental chairs, which will be utilized in the prevention issues like the fissure sealant in the primary dental health care centers. We are working now, it's in the final touches in web-based electronic statistical forms, which will be available through this link, where all the regions can just go and enter their statistics in that form, and all these forms, a copy will go to the school, a copy will go to the dental directory, a copy will go to the regional directory, so all will know exactly where is their situations in the initiative. More collaboration with the private sector. We have good collaboration with the private sector now, and we are trying also to make it in an agreement form that many of or whomever wants to join is most welcome. We are now collaborating with the Colgate company. They distributed free samples, more than, or I should say, around 300,000 samples during the last semester. Always we say, when there is a will, there is a way. The prevention way is not simple, is not short. We have to, there is too many obstacles in terms of funding, resources, manpower. Everything is, we are facing. It's not just like a drill and fill approach. You are going to the field, you are leaving your clinic. It needs lots of effort. But we started, and this is a new initiative. We hope it will add on the changing of the picture for dental care statistics in Saudi Arabia. Thank you all for your good listening.
I would like to thank you, Dr. Adel, for the nice presentation, and I have some questions for you.
Sure.
First of all, have you thought about initiatives to tackle younger children? Because when I collected my data for my PhD, it was on first grade primary school, and it was a disaster because most of them, they have caries. And if you want to prevent caries, you should start earlier. So do you have any initiatives to tackle younger children to prevent caries? Because otherwise you will not prevent caries in primary teeth because they have caries already. This is my first question. And the second one, the data will be, the data from your surveys will be available for everybody to enter and to see the data, or we should have access, special access to this data. And thank you very much, and I hope this initiative, the success for this initiative.
Thank you so much, Dr. for your comments. Regarding the first question, the initiative for other or younger children, we have, but still it's in the planning process. We tried to make it as a part of this initiative, then we said no, it's better to be another initiative that has other goal, other scope of services, other activities in the kindergarten and or in the like in the KG1 or KG2, and so we are still it's in a I should say in a primitive stage now. We are just in the scratches, doing the scratches, how to implement it, but it's in our mind. So thank you in this regard, Doctor. The other question regarding the data, it's available for the school health department, for the dental department, for the different dental department in the different regions. Also for each school, it's available to see their data regarding their children, regarding their students only. Okay. And if anyone he or she likes to have those, we could inshallah share it with you, but it's not available online. You cannot
Dr. Adil, thank you very much for this presentation. I was looking forward al-haqiqa to hear about this because we didn't hear about it until recently. My question would be, are there any way of quality or calibration for placing fissure sealants? I'm not talking about the screening part. I know for sure you guys have calibrated your examiners to screen the kids, but I'm talking about the efficiency of application of fissure sealants when it comes to general dentists at the Ministry of Health, primary health care centers, or at other clinics. The reason why I'm asking this is that we don't want to have a really vast number of fissure sealants that are being placed. Somehow, let's say a percentage of it is not being done properly, and then caries will start under the fissure sealant and will have the problem magnified later on. That's my question.
Thank you so much, Doctor. Thank you for your nice comment, Doctor. But regarding the quality, let's say it in this way, the quality of fissure sealant. Let me tell you a story. Before when I went to a field trip one day, I was seeing the dentist who's applying dental sealant in the schools, because this is a continuation of a previous initiatives where we have an initiative of a school-based. It's not a school-linked like this program. It's a school-based sealant program. Then I asked the dentist after he finished, "Did you finish?" He said, "Yes, I finished." Okay, and I know that he didn't do a good isolation. I just took the Explorer, take it out with an Explorer. I said, "Okay, you did nothing but etching the tooth." Okay, so now we change it to a school linked program where the sealant will be placed in the primary healthcare centers, and we assume that the environment of applying, in our situation, and applying the dental sealant in the primary healthcare is much far better than applying it in the school environment. But it's an area of research also, and if you could comment on that, Doctor.
Just a quick comment. I think most of the public health programs, when they do fissure sealant, well, I don't want to say all, but the majority will go and choose Fuji's, like GIC, fissure sealants instead of doing the resin-based ones. Given the fact that even if there is some sort of contamination from saliva, the sealant will still work. So that's a recommendation that you might, tell the superiors about.
Okay, thank you so much, Doctor.
Thank you, Dr. Adil, for your nice presentation. On behalf of the organizing committee, it's my pleasure to submit to you this certificate of appreciation.
The next speaker for today, Dr. Birdosis. He received his dental degree from the National and Pedestrian University of Athens Dental School and his certificate in pediatric dentistry and master's in oral biology from University of Medicine and Dentistry of New Jersey, USA, and PhD from the University of Athens Dental School. He has worked as research fellow of the Brookhaven Laboratories in New York. He's working in Athens at his private practice limited to pediatric dentistry and orthodontics, and as part-time clinical instructor at the University of Athens Dental School. He has taken part in 2 European research projects funded by European universities and in 1 national Pathfinder study for oral health status and treatment needs in Greek populations. He has published in national and international journals and has lectured in national and international congresses and seminars. His primary interest is dental informatics, caries diagnosis and prevention. He's also co-author in the textbook Dental Informatics Principles, Means and Applications. Dr. Berdosis has served as Secretary and Vice President of the Hellenic Academy of Pediatric Dentistry, and currently is the Secretary of European Academy of Pediatric Dentistry. Please let's welcome Dr. Elias Berdosis to present clinical early diagnosis of dental caries on permanent teeth, current evidence. Thank you.
Good afternoon. Thank you very much for the invitation and all the hospitality I have received until today. This presentation will talk about the clinical early diagnosis of dental caries on permanent teeth. A little bit for the background. We all know that there is a decline in dental caries all around the world. There are many reasons for this. But this decline has changed also the location where these cavities, these caries, is located. And there are also changes in the size, the shape, the progression of the lesion. And also these lead to the change in the approach of the treatment and in the recent years. So what we need now is we need new technologies of detection, diagnosis, and treatment of caries lesions, so we adjust to the change of the disease. We know that if there is no cavitation, we most of the time can intervene preventively and stop the progression. If there is a cavitation, depending on the length, we can use minimal invasion techniques, or instead of the old dogma of extension for prevention, to use sealing for prevention. Just to, this is a very interesting study just to show how confusing can be for us and for the patients when they try to look what is the problem with their teeth and how many cavities they have or how many caries they have. This is a study that occurred within the NHS system. Dr. Natal examined 720 patients. Then he let them go to have treatment in NHS system, and he evaluated them again 1 year later. Out of the 720 people, he re-examined 281. These people presented with 559 surfaces that they needed restoration. When he re-examined them 1 year later, they had received 1,153 restorations. So they were double the treatment from what he initially thought. But the most striking thing is that only 131 cases were the same. So there was a lot of untreated caries left and a lot of over-treatment done. So this illustrates the point, what we are trying to do with all the systems that we have tried to implement in caries diagnosis. And of course, the problem of diagnosis is not this. This with saliva, without saliva, any way you look at it, it's caries. Maybe this is not a problem either, but this is a healthy tooth. When the problem starts now, when you see some areas, they start changing color, then you start thinking this is the shadow of the light, or this is the stain of the area. Is here any missing tooth structure in this area, or this is something that this is the tooth. This is the way the tooth is made. Now you see more stain. Start thinking about it. And then you come to this. So you looking into trying to diagnose different areas, you come into different shapes and colors. And that confuses the dentist and the patient in the long run. What we know also about occlusal caries is that they start earlier. They're more difficult to treat because we don't know exactly what to do with them, when to intervene, and expand faster than the interproximal caries. We saw earlier a presentation that says that in permanent teeth, that you have maybe 5 or 8 years before they reach dentin. You will see here when the caries start at the bottom of the fissure, depends where the fissure is, but this is one of these cases. Some other times they start at the side of the fissure, and sometimes are only on the top and nothing happens at the bottom. But many times there is no enamel between the dentin and the bottom of the fissure. So if something starts down here, you are in the dentin essentially. So there is no time to react. So this poses different problems when we try to diagnose caries. And conventionally, we were relying on the three things of the visual examination, the explorer, and the radiographic examination. And now we know, after all the knowledge that we have accumulated over the years, that in order to have a visual examination, there are some things that are very important. One is the correct working position. The second thing, which is very important, is the light. We have to have enough light. We have to have a very clean surface. We have to have means to dry the tooth. And some of us, with an age, we need a magnifying device. The main thing that we require the drying is that the refraction rate, the refraction index of enamel changes as the decalcification of the enamel advances. So sound enamel has 1.6, and the demineralized has 1. Here it illustrates how different you see the same surface just by drying the tooth. Things that you cannot see on a wet surface are more pronounced on in the dry one. So the visual examination is a very simple procedure, has a high specificity, but the sensitivity is not so high, especially if the cavity is in very early stages. The more advanced is the cavitation, the more accurate is the technique. Also, another problem with the visual examination is that the outcome depends on the experience of the dentist. And the more cavities, the more cases you have seen, the more cases you have talked with with colleagues, the more you understand about these early lesions. Also, the judgment, it is many times it is affected from the stains, and many times you don't know how you deal with them. So over the years, they have tried to implement many different criteria. There are many, in the literature, there are more than 15, 20 different systems. One that was the more effective was the one that Extract presented first initially in 1997, and it was evolved to what we know today as ICDAS-2 in 2005. I'm not going to go through the criteria. I'm sure all of us have an understanding, but with using this index, we can classify the caries in different categories according to how deep and how if there is enamel loss or if there is dentin involved. So using ICDAS, we have the ICEDAS system, it's again more accurate when we have deeper lesions, has a very good reproducibility, sensitivity, depending on the stage of the lesion, as we said earlier, and the same it is with specificity. But this is I believe this is the best we can have under the circumstances for the visual examination. Because if we have switched away from whether there is a cavity or not, because the classification into different categories gives us an idea how we treat them. So when we use ICEDAS system, what we do is we look on the tooth and we make a decision. We don't touch the tooth. So the next question comes, okay, if we take a picture of the tooth and we evaluate it, can we come to the same conclusion? So there are a couple of studies. One of the first ones was in 2012, and it showed that direct, meaning in vivo, and indirect on the picture evaluation gave very, very similar results. This evaluation through the picture, it definitely is affected by magnification and other factors, but if you keep the size of the tooth when you evaluate it in the one-to-one magnification, you're very close, you're judging the tooth in a very similar condition like what happens in the mouth. And this gives us the possibility of treating then this picture as if we're looking at the tooth. And we will come to that a little bit later. Another means is the Explorer. I'm not going to go very much into this. We know that we have to be very careful using the Explorer in the mouth. It cannot differentiate between stages. It is a tool that we have to use very cautiously, even from 1987, Ekstrad, Quist, and Thelstorp mentioned that it can destroy enamel. This was verified under electronic microscopy from Munich. So we have to be very careful when we, these come on. These areas here are done on a mildly decalcified enamel, and the Explorer was just scratching the surface. It was not pressed on the surface. And still you can see the effect that it has. So we have to be very careful with it. So what we need to do is we have to have a sharp eye, as one of my professors was saying, and a very blunt Explorer. Then we have radiographs. Radiographs are a good means to assist, but they have limitations when it comes to detecting caries that are in enamel only. If the caries have reached the dentin, then the radiographs can give us a very good idea that what happens. So we need, it is a mean that we should use when we try to detect caries, but there are in the very initial lesions, they are not that effective. Saying this, we understand now why, if we look in the literature, we'll see so many techniques trying to evaluate initial lesions, because there are limitations with the visual examination. And trying to, using non-invasive, of course, techniques. These new techniques, working under the thinking that if the initial lesions, the enamel in the initial lesions have changed chemical composition and physical properties, then we should find a technique that can identify and measure these changes, and then in this way we can understand whether there are caries there and what kind of caries there are. One of the most common phenomena that were used to evaluate initial caries is the light fluorescence. The basic concept of all these devices that they use the light is that when we illuminate enamel with light, then the phosphorus and calcium and all the metallic ions of the enamel have a fluorescence property and emits back light in a different wavelength, a higher wavelength. So if we catch this, and if we catch this wavelength and measure it, then we get an idea of what happens in the enamel. On the contrary, when you have decalcified enamel, there is less metallic parts in the tissue, and then you don't get the fluorescence. There are many fluorescence devices like QLF, Diagnodent. Some of them are in the blue spectrum, close to the blue spectrum, and some to the red. One of the first one was Diagnodent. On the right side, you see the old device. On the left, it's the Diagnodent pen. It is a laser diode that illuminates the tooth, and the device takes a reading from 0 to 99. Here are the different tips for the different areas. The device can detect initial lesions. It cannot, in order to differentiate between the different stages, we need to have the cutoff points, as we say. Lucy in 2001 proposed a grade from 0 to 13 as a sound enamel, 14 to 20 as enamel caries, and more than 20 the caries are indenting. But this is not 100% accepted by everybody. And also, we don't have similar cutoff points for primary teeth. It is a very good device that it can evaluate the progress of a lesion, but it is not a device that can give us a definite answer whether there is a occlusal initial cavitation or not, especially on the occlusal surface. On the smooth surfaces, it is a little bit more accurate. Now we have wavelength, the QLF. This is the quantitative light fluorescence. Initially it was with argon laser, then they became with xenon laser. It is a similar technique, but with a different wavelength and a means of evaluation. It is the regular tooth, the healthy tooth is presented as green. The tooth that has it is a demineralized, the areas that are demineralized, they look darker. So the appliance, the machine makes a comparison between these areas, and it comes into a decision where there is a caries or not. There are problems like because calculus and plaque interferes with readings. The light, the ambient light is very important. The angulation of the tip is important as well. So it is very sensitive as a technique, and the dentists have to train a lot in order to interpret the results. And also there is they believe that it gives an idea about demineralization areas that only up to some microns. It cannot read deeper. And finally, it's a very expensive machine to detect caries. Then we have Vistacam. It comes from Dur. It is a second generation. Same again, it illuminates the tooth. There is a filter, high-pass filter, and there is a software that evaluates the pictures the camera gets. The green is the tooth. Again, the tooth has a green color, and then this is not the right color. This is a pseudo color that the appliance does. It gives you the different colors. Red, blue, and yellow comes from this scale, and it gives the initial stages, and it gives the different stages of depth of the enamel. So this is, it has a good sensitivity, acceptable, good specificity, but we don't have many studies that they have reproduced the results. We need more information about it. And the past few years, there is there are not so many studies with this device. Then we have another type of light, the 40 and the Q40 and the Caris ID. I'm sure all of us, we have heard about 40 and the digital 40. It's a device that it illuminates the tooth from one side. I'm not going to go into details about this. It's a very common device that most people have seen. The problems with 40 and digital 40, it is affect the reading. It is affected by the stains. It cannot give you the location of the on the occlusal surfaces. It cannot give you the location of the lesion, because you get a reading on the surface from a 3D structure. So it has a very limited help in especially on occlusal caries. Then we have the Midwest, which uses a soft LED white light. Again, this appliance gets the reading from the fluorescence, and the device changes the color and the sound when it comes into a decayed area. There are very few articles evaluating the device. It shows good sensitivity, but also it's affected by the plaque and the calculus and the organic matter. And of course, when we evaluate the occlusal surfaces, we have cleaned the surfaces, but inside the grooves and the pits and fissures, we cannot clean. So whatever is in there interferes with the reading. If we go beyond those fluorescent light devices, there is a whole list of different techniques and devices that they have been used to evaluate the caries. Electrical resistance was one of the first one. The device now, it's about 5th generation. It has gone through a spot evaluation to surface evaluation, a canary system that has different types of thermal imaging and fluorescence, ultrasounds that they go perpendicular to the tooth or along the surface of the tooth, optical coherence, infrared thermal imaging. The near-infrared imaging, this is a promising area of light, and I think this is something that we will see in the near future. The light in this area gives a very good understanding about decayed areas, where the blue spectrum of light gives an idea about decalcified areas of the tooth, MRI, Raman spectroscopy, and everything else. So just by looking at the list, we get again the idea that still we don't have the best technique that we can have to evaluate initial caries. So what we did with, what we thought, looking into all these